All right, welcome everyone to section 5. This is the final section here. This is on the restricted drugs component. We're going to cover chapters 13, 14, and 15 here. And just as a forewarning, this is probably going to be one of the longer sections. But again, I'll put in those, those markings throughout so you can skip to different chapters if you'd prefer. All right, so let's go ahead and start off with chapter 13, which is opioids. So we're going to talk through opioids here and talk about some of the early forms of where they started, some of the history of opioids, talk about how this transitioned into prescription opioids, the pharmacology of how these tend to work, some beneficial uses of them, as well as some causes for concern to kind of wrap this section up. All right, so let's go ahead and talk about some early forms of opioids. So opioids really come from opium, right, which is a naturally occurring substance that comes from the poppy plant. You can see an image of that over there on the right. So this has roughly around a 6,000 year long history of medical use to it. So it's been around for a while. It's been used by a lot of different people for different types of medication and pain relief use. But it really falls under two different kind of categories, right? So there's morphine or chemicals, I should say. There's the morphine component and the codeine component. We'll talk about both of these and kind of how each one works and what it does slightly differently. We've also kind of developed this into some more synthetic drugs as well as heroin here as well. So let's talk about these three. Let's talk about morphine real quick here. So morphine is really the primary ingredient in opium, right? So this was first isolated from opium in 1806, so not that long ago in that 6,000 year spectrum of time. And it's named Morphium after Morpheus, the god of dreams, which is kind of fun too. And it's about, when isolated, it's about 10 times as potent as opium itself. And then we have codeine, which is the secondary active ingredient in opium. And that was first isolated in 1832, so almost 30 years after morphine was. And this is named after the Greek word for poppy head, right? Because remember, this comes from the poppy plant. So two components that make up opium here. So morphine, actually, the use of morphine spread more so for a couple different reasons. It spread primarily for the technological development of how this came to be. So hypodermic syringes, like needles, allowed the delivery of morphine to be injected directly into the blood. And this technological development of those needles allowed this drug to, again, be really easily administered, and the spread of this drug kind of just took off. This was around 1853 when this kind of became a thing. Also, political development played a role here as well. So it was used pretty widely during the war to provide pain relief for soldiers. And so this was sort of a big component here. And a lot of veterans actually returned addicted to morphine, which, was a huge problem. And actually, it was later called the soldier's disease or the army disease, was this addiction to morphine. All right, let's talk now about heroin. So heroin is sort of the next derivative of this as well. They actually took morphine and worked it in some laboratories and actually were able to create heroin. And heroin is about 3 times as potent as morphine, and it works in a slightly different way. So what they did is they took these two acetyl groups that were actually bound to sort of the chemical structure here, and were able to, again, isolate them and create heroin, which is actually more readily able to get into the brain through the blood-brain barrier. So it increased that solubility of heroin to make it more potent and more able to be, again, taken into the brain. This was originally actually marketed as a non-addictive cough suppressant that would later on end up actually trying to replace codeine. But of course, we found out later on that there's some high dependence and factors linked to this. All right, so the history here a little bit of this opium use and abuse really kind of centers around the Harrison Act. So the Harrison Narcotics Acts of 1914 was kind of a turning point. And so we'll talk about the use before this as well as after this. So before the Harrison Act, really the use of opioids was not really viewed as a major problem. So most people didn't really see an issue with this. There weren't many social issues with it. And most patients took these medications either orally or sometimes even in different cultures they were smoked as well. Of course, then we got to the injection of morphine, which is actually one of the most dangerous forms because of that high potency and quick ability for it to be absorbed into the blood and into the brain. About around this time, we're talking around the start of the 20th century, sort of, we saw almost as high as 1% of the US population was using morphine or opioids, I should say, on a regular basis. And so it was relatively not viewed as a major social problem. Then we had the Harrison Act. So this basically so you can see here, the Harrison Act, right? It regulated and taxed the production and distribution of opioids, as well as other coca or cocaine products. And we talked about this in that chapter as well. So once this sort of came about and took place, everything kind of changed. So the only way to get these drugs now were through illegal means or illegal dealers. And this really changed the pattern of users and public perception. So oral use declined, right? Those oral medications declined because people weren't able to get that. And really the main method that remained was injection, right? So now really these illegal dealers were the only way to get it, and they tended to spread the liquid injectable form of these opioids. Most of the people who remained or continued to use them injected heroin specifically. And then, of course, because of this, the cost and the risk increased, right? Remember, heroin through that injection or intravenous method is the most dangerous form. And so, the users became addicted to the substance pretty quickly, and they began to be seen more as criminals rather than victims. So there was kind of, again, a turning point here. Also, we see this use in Vietnam was a big part here as well in around 1971. This was partly because, again, heroin in Vietnam was pretty inexpensive and easy to obtain. And so about 5% of people in this case, soldiers were, take that back. I read my notes wrong. So actually about 5% of 100,000 people just in the US that were tested positive for some form of opioid use. So this had increased from 1% before to about 5% now, which is kind of wild in this case. One of the other issues here, when we talk about the production and the purity here of opioids and heroin specifically, is the change in the strength of these. So over time, they've gotten stronger and stronger, which of course leads to more issues that come about from this. So in the 70s and 80s, we saw that purity only at about 4 to 6% here. However, in 1989, that rose to about 25%. And now today, most of what we see on the streets tends to be somewhere between 51 to 83%, which is really kind of wild here when we talk about heroin specifically. And of course, recently we've seen issues with fentanyl being kind of mixed into that, which is another kind of similar substance, but has a much lower lethal dose. So we have that range. Remember, we talked about this in previous chapters. That range of effective to lethal dose on fentanyl is much narrower, and so it's a much more dangerous drug here. All right. So, of course, we have opioids that come in prescription form as well. So, we talked about kind of the heroin side of things, but now let's talk about some of the prescription forms of opioids here as well. So, some examples here are things like hydrocodone, some typical names, things like Vicodin or Lortab, and then also oxycodone. So, Oxycontin and Percocet are examples of these as well. And so this really was it's a pretty prevalent thing and has been for a little while here in the U.S. We see sort of similar trends to this that we saw to the opioids before the Harrison Act. So in 2018, about 1% of Americans reported use of these medical opioids in the past month. So about that same 1% of US population kind of using these on a regular basis. Most of these tend to be administered orally, though some are sort of injected through the nose or even, through hypodermic needles. So when we talk about, again, this safety concerns here with these, most of the time, when we talk about overdose, we talk about more serious safety concerns with these tend to be when they're combined with some other sedative, usually alcohol. So if you take these and you're drinking alcohol, that's usually when you start to see more of these overdose issues occur. But on their own, that's much more rare of a thing to see. So when we talk about this, we talk about how they work, how they overdose, but let's actually get into the pharmacology and how they actually work so you can start to understand how this might happen. So let's start off actually talking about the mechanism of action here and how these opioids kind of work in the brain. So there are some naturally occurring opioids that just we have in our brain, and you may have heard of probably one of these. So we have enkephalins, which are found, again, in the brain. They act like morphine and are actually more potent. We just obviously have less of them than morphine. And then, of course, we have endorphins, right? So these are also morphine-like substances and have that same potent opioid effect. And again, these are naturally occurring. We produce them ourselves in our brain. What their job is to block the inhibition of dopamine release. So we also have neurotransmitters that go in and they block dopamine from being released. And what these do is they stop the stopping of dopamine being released. So it's kind of a double action here. But they stop that release. You can see in the image here, they bind to that opioid receptor, which stops those inhibitory neurotransmitters from being released, which would normally block and stop the dopamine from being released. So with less of these inhibitory transmitters, we get more dopamine in the system. So more of a dopamine effect. We can actually look at, let's see, we are on, let's go ahead and run a mouse party here for specifically, we'll take a look at this for heroin and kind of see how this works and show kind of an example here. So when we look at the heroin mouse, or the mouse on heroin, I should say, we're going to zoom in here to the brain and take a look. Again, so naturally occurring, what happens is these inhibitory neurotransmitters, these little blue triangles, come in and they bind to these receptors and they stop the dopamine from being released into the system. Remember, dopamine is that neurotransmitter that is responsible for sort of those positive effects, positive mood, feelings of wellness, depending on where it occurs in the brain. So normally, this is what happens. This is normal functioning here. Then what we see is our native opioids, the ones that we naturally produce in our brain, those endorphins, things like that, will come in and they'll bind and stop those inhibitory neurotransmitters so that we get more dopamine because it's not being inhibited. Again, that's the natural process of what happens in our brain. And basically, what these opioids that we ingest do is the same thing. It just means there's more of them in our system. So there's more inhibition of those inhibitory neurotransmitters. So again, more and more dopamine is able to flood the system and bind to those dopamine receptors, causing more feelings of positive wellness, euphoria, things like that. And again, we can see this effect based on where it's acting in the brain. And this has a pretty wide range of effect on the brain in a lot of those stress, mood, emotional areas of the brain. So again, that's an example of heroin specifically, but most of the opioids work in a very similar fashion. So we'll go ahead, we'll eject him, and we're going to come back to Mouse Party a few times. We're going to look at the rest of these mice as we go through the rest of this chapter. All right. So when we talk about these antagonists or things that kind of work to block the action of opioids, we also have medications like naloxone or nalorphine, right? And these are helpful at reversing the effects of the opioids that have been taken. So they can be used to both help with withdrawal symptoms as well as potential overdose of these medications. So they, again, can help kind of with that process of trying to reduce the number of people that are dying or, succumbing to overdose with these different forms of opioids. So of course there is some beneficial use here. You can see, the negatives tend to outweigh the positives for these, but there are some beneficial uses. So we do have effects on pain relief, right? That is their main sort of effect, is that they reduce the response to pain. And so this can be helpful in certain circumstances, especially extreme settings where, lots of issues tend to take place. They also, interestingly enough, can help treat different intestinal disorders. So they have a solidifying effect to the fecal matter, so they can be helpful in treating diseases like severe diarrhea and things like that. And of course, they also act as a cough suppressant, so they can reduce that effect of coughing, which can be beneficial in some circumstances. Though I think now we have other types of medications that do these without quite as many of the negative side effects that these opioids have. So let's talk about those negative side effects or those causes for concern. So of course, we have issues with dependence, things like quick buildup of tolerance, so you need to increase your intake to get those same effects. Of course, physical dependence happens as withdrawal from these tend to be very unpleasant, but unlike barbiturate withdrawal, like alcohol, they're actually pretty rarely life-threatening. So remember, withdrawing from alcohol can actually be life-threatening. You can succumb to severe seizures and different things like that when withdrawing from alcohol. Typically, withdrawing from opioids, even heroin, tends to be very unpleasant, but very rarely life-threatening. So when we talk about sort of the toxicity here of these medications, we'll talk about it both acute and chronic when we're looking at this. So when we're looking at the acute toxicity here specifically, what it does on a short-term scale is it tends to depress the respiratory centers in the brain. So you're going to get probably slowed breathing, slowed oxygen intake, things like that. And so these antagonists, the things that try and reverse these effects, tend to stimulate those areas. So that's more the acute side of things, is that general depressant effect on the system, specifically in those respiratory centers. That's sort of the most toxicity potential here, is on the respiratory center of the brain. However, for chronic use, mostly associated with the injection of these medications, tends to be, the biggest cause for concern here are those needle-borne diseases that can be transmitted and spread through blood, transfusion. So that's typically the most, the highest cause for concern on the long term tends to be those diseases that can be spread. There are some misconceptions or preconceptions about these that I think it is worth kind of addressing and talking about. So most people believe that injecting heroin or morphine gives this sort of intense pleasure, like unequated by any other experience. And while this may be true in some people, many people actually report feelings of nausea and discomfort, but they still continue to use it. So it's not necessarily this, be all end all experience, but there is this immediate and strong sort of reinforcing effect that does still occur. Tolerance to these negative effects does tend to build up more quickly compared to the positives. So that's why people, tend to continue using it as well, because those negative effects subside. You build up tolerance to those while you maintain those you maintain those positive effects. Also, some misconceptions are that withdrawal is always like terrible, excruciating pain. And oftentimes, especially for users that use low or daily, low uses of this, withdrawal can sometimes be similar to like, a case of the flu. So it's certainly not pleasant. It's certainly not a good time, but it's also not, completely excruciating in the sense that you might expect it to be. Another, more common misconception here is that, one injection gets a person addicted for life. And oftentimes this isn't necessarily the case. It often takes time and persistence to really kind of get to that point, though it is certainly possible for that to happen. All right, so that covers our opioids chapter. So we're going to go ahead and switch over now to chapter 14, which is all about psychedelics. All right, let's cover chapter 14, psychedelics. So a few things we're going to talk about here with this chapter. So we're going to go through some terminology and classification first of some of these different terms that you'll want to know and be aware of as we go through. We'll talk about what are known as indoles, a type of psychedelic medication that falls under some category, or some categories that fall under this, like LSD, psilocybin, and some others. Then we'll talk about catechol, which are a different category, things like mescaline or some amphetamine derivatives as well. And so when we talk about these, again, we're mostly just going to kind of cover the general different types of psychedelics because there are so many here to talk about. And we'll give some examples as we go and talk about some of the methods of action and pharmacology of these along the way as well. All right, so let's talk about some terminology and classification first. So the first term I want you guys to sort of be aware of is this term animism, right? So this is the belief that different objects can attain certain characteristics because of spirits contained within them, right? The idea that, like the animal side of it, there being animal spirits sort of associated with different things. And this was a component of sort of early use of these, psychedelics that caused people to sort of have more, religious association and ties to the use of these. So the idea here was that if a plant contains some form of spirit, then eating the plant or consuming the plant transfers that spirit to the person who consumes it. And this was the idea for a lot of these early psychedelics, which we'll see derive from different forms of plants. We'll also talk about some different psychomimetic drugs. So these are basically drugs that, quote, mimic psychosis, right? So the idea that drugs produce some dangerous form of mental disorder. Now, they're mimicking it. It is not permanent most of the time in this case, but it is sort of a way to classify certain types of drugs. Producing hallucinations, altered sense of reality, basically a state similar to that of psychosis. Then we'll talk about psychedelics. So again, these are drugs that are altering your perceptions while still allowing the person to remain in control or in communication with the present world. So somewhat less of an actual disconnect from reality. So they provide awareness of both sort of the fantasy world as well as the real world at the same time. And these are the drugs that we tend to group according to their chemical structures, either the indoles or the catechols. So we'll talk about those. Also, the term ethogen, which is a substance that creates spiritual or religious experiences, just a term to be aware of, as well as entactogen, or a substance that enhances the feelings of empathy. And many of these drugs we're going to talk about induce feelings of both of these two things. All right, so when we're talking about the classification here and how we kind of organize these different types of psychedelic drugs, because there are quite a lot of them, and so we have to have some sort of organization to this. We kind of classify them in two different ways. First, we tend to potentially, or we classify them either by their chemical structure or kind of by their effects or their properties. The two major ways that we classify them through their effects is either those that alter perceptions while allowing the user to remain in communication with the present world. So you kind of experience both sides of this. And then, of course, those that produce so much, delirium and mental confusion, sometimes even loss of memory, that you kind of are void of any sort of connection to the real world. So those are kind of the two ways we can classify drugs in this case in terms of their effects. We also can classify them based on their chemical structure, which is how we get those two categories of the indoles and the catechols, right? So indoles are drugs that basically have the same basic indole structure of the neurotransmitter serotonin. So if we think about serotonin and the effects that it has, these are drugs that kind of mimic that structure. Some examples of these are like LSD or psilocybin, come from mushrooms, that these sort of contain the structure and mimic this effect. Then we have catechols, and these are drugs that have the same basic structure of the neurotransmitter norepinephrine and dopamine. Things like this are mescaline or even MDMA or ecstasy are examples of this type of psychedelic drug. All right, so let's go through kind of each of these and talk a little bit about them. So we'll start off with LSD. So LSD actually stands for D-lysergic acid diethylamide. I know that's a mouthful, but that is why why we call it LSD. So this was actually first synthesized back in 1938 by Dr. Albert Hofmann, and so he actually synthesized this chemical. And believed to understand what it would do, and actually took a large dose himself a few years later, around 1943, and noted its hallucinogenic effects. So he basically created it and tested it on himself to come to the conclusion of what LSD sort of does. And the potency of this drug sort of attracted attention from other people. So if you compare this to other drugs like mescaline, which we'll talk about here in a minute, it would require about 4,000 times more than is needed taking that amount of LSD. So pretty potent, pretty strong chemical in small amounts is LSD here. In terms of some early research on this, so often between the 1950s, 1970s, a lot of research was done on LSD, and some attempts were made to develop different models of psychosis, as well as using LSD to access our subconscious mind. So again, kind of some interesting studies that were done back in the day on how this drug might help us to sort of unlock or see parts of our brain that we aren't normally able to access. And also, because of this, it was widely used as sort of an adjunct or, a supplemental component to psychotherapy. Around 1970, the government actually stopped funding LSD research and kind of moved on from this for many different reasons. Of course, there was also many recreational uses of LSD as well. So there was research done on the recreational use of LSD, as well as just some, general use of it throughout the 1960s and 1970s. The recreational use peaked around the late 1960s. So that's why we kind of get that, we typically think of the hippie movement, if you will, that existed in the 60s and 70s. But that peak was sort of right in between those two decades. When we talk about the pharmacology of LSD, or how it kind of works here, really it's usually taken orally. You can see kind of in the image, there's these little pieces of paper, and usually the LSD is administered on the paper. It absorbs into it, and then these little strips are what's taken orally, and it kind of diffuses onto the tongue. And this is absorbed through our intestinal tract, and so it's a little bit of a slower absorption process. It's metabolized in the liver, just like many of the other drugs we've talked about, and is basically excreted as a non-active version of itself. The half-life is about 3 hours, but it can have some longer lasting effects as well. In terms of tolerance tends to develop pretty quickly. So if you're using it, 3 to 4 days of daily doses, you're going to already start developing some tolerance to this drug. And there's also cross tolerance between other of these types of hallucinogens. So things like mescaline and psilocybin can have cross tolerance with LSD. There's been no demonstrated physical dependence to LSD or really to any other psychedelics to this point. So that isn't really something that comes into play with these. They don't really affect the body physically, really more just the mind. Let's see here. So in terms of the method of action specifically, we can talk about this in how it mimics our serotonin receptors, right? So the best evidence that we know of is that it's stimulating these serotonin type of receptors and kind of producing similar effects of excess serotonin in the mind. There are some beneficial uses we can talk about here. So it can have some positive subjective effects, right? Mystical experience, also sometimes ego dissolution, or the idea that you as a person don't really exist and you see the world as one sort of unified component. And it has sort of this benefit or positive subjective effect, I guess, going on. However, of course, there are, some other things that it does. We'll call these sort of neutral effects. Things like disrupting the ability to concentrate, distorting the sense of time, slowed thinking. These I would say are neutral, leaning on the side of negative, but could be used in certain circumstances for their benefits. Again, other research has been done on this, looking at things like the treatment of alcohol disorders, or reducing even cluster headaches, which it has shown some potential benefit towards. In terms of the adverse reactions of the negative side effects, the main one that tends to be brought up and talked about are what's called flashbacks, right? Which is the idea of basically people in a non-drug state, so haven't consumed the drug, re-experience one or more of the perceptual alterations of the drug when they were taking it. So they're basically sober at the time, but then sort of have these flashbacks of feelings of when they had consumed the drug. Now, this tends to be pretty rare, but is something that has been documented and could be seen as a potential adverse reaction. All right, the next drug to talk about here is psilocybin. So this is the the psychedelic component that comes from mushrooms or magic mushrooms, right? So this is the idea of this chemical that is found and is produced naturally through different forms of mushrooms that grow, in the wild. There's been research done on this, looking at the effects of psilocybin. Especially more recently, they've looked at things like microdosing, taking small amounts of the drug, and how it can have some positive effects. Most of what has been seen with this tends to be used for treating things like depression, or other negative psychological components. And a lot of the research here has shown some positive effects, especially when taken in small amounts. In terms of the acute effects or the short-term effects of this drug, we tend to see that you get changes in mood, perception, and thought Most of the time, the experience tends to be pleasurable, enriching, or even euphoric. But sometimes you can see some negative effects as well, some negative mood effects, as well as headaches or feelings of anxiety or things like that. So there are definitely positives and negatives to this as well. In terms of the chronic effects or long-term use, relatively little is actually known. Most studies haven't really looked at the long-term effects of this. One study indicated that no subsequent drug use persisted when looking at sort of long-term impairment of participants that took specifically psilocybin for long periods of time. I think that, like I said, there's very little research actually looking at this, so I would take that with a grain of salt. I think there is certainly the potential for long-term negative side effects with this as well. All right, let's talk about a few other of the indole classification of hallucinogens. We have some examples like morning glories. These are a form of flower that produce a chemical that has other forms of hallucinogens under the indole category. We have Hawaii baby woodruss, another flower, similar thing. Let me see if I can get this one out. Dimethyltryptamine, or DMT. You may have heard of this before. This is actually a chemical that is produced in our brain often when we dream, and can produce sort of those dream-like states, but it also can be synthesized and taken as a hallucinogen as well. Ayahuasca, which is another form of plant that is oftentimes distilled down into a tea or some other form like that. And then, of course, other tryptamines that kind of fall into this category as well. There's quite a few, but you can see most of these tend to be derived from some kind of naturally occurring plant or something in the world. All right, so those are the indole categories. Remember, those structures that tend to mimic the serotonin neurotransmitter. On the other side of things, we have the mescaline forms, which are those that kind of mimic the dopamine receptor here, right? So our first example here is peyote, which is, again, derived from a cactus. It's a carrot-shaped cactus, what we see in the picture here, small, spineless. And it actually has more than 30 different psychoactive compounds inside this peyote cactus. But once it's sort of synthesized down, it can create sort of a drink or a tea that people take for different reasons that produce similar effects of the other hallucinogens, vivid colors, and other visual effects as well. When we talk about this, we can also talk about some different cultural use that has been used, or that mescaline has been used for in the past. Actually, the Native American Church incorporates peyote into its ceremonies. So it's definitely a traditional practice of different Native American cultures. And that has brought with it some different legal issues, right? So in 1990, the Supreme Court actually ruled that the state of Oregon could prosecute its citizens for using peyote. So part of the problem there is that, of course, there's going to be Native American tribes sort of in that region. And then back a few years later in 1994, Congress passed a law saying that no Indian shall be penalized for using peyote, so for legitimate traditional purposes. So kind of, overruled that 1990, at least for people of Native American descent using it for traditional purposes. So again, there has definitely been some sort of legal, dispute back and forth on this and how it can be used for those cultural and traditional uses while still keeping it under control, sort of from a FDA perspective. When we talk about the pharmacology of this form of hallucinogen, typically it's ingested orally, similar to the other ones, which means a longer metabolism, right? It takes a little bit longer to go through that digestive tract and to be absorbed into the body. This actually has a longer half-life than something like LSD when we were talking about this, with a half-life of closer to about 6 hours. So it's going to have a much longer sort of effect here. Remember, half-life is not the amount of time it's going to last. It's the amount of time that it takes for half of it to be broken down in the body. In terms of tolerance and psychological and behavioral effects, we can talk about sort of, in low doses, it tends to produce primarily euphoric feelings, and in higher doses can actually give rise to full-on, hallucinations in this case. Tolerance tends to develop more slowly to mescaline than to LSD, but there is some cross-tolerance there as well. When we talk about building up tolerance to one, like LSD, can produce tolerance for the other form here as well. All right, so that kind of covers the mescaline category. So let's talk about also some amphetamine derivatives in the form of psychedelics. So we're kind of now shifting gears a little bit here when talking about this. So a large group actually of synthetic psychedelics is chemically related to amphetamines. So we talked about amphetamines before, and some of these psychedelics that are produced or synthesized have some chemical similarities to them, the amphetamines. So we can see similar effects when we talk about these. Some examples of these are things like MDMA or ecstasy, right? So this particular substance, psychiatrists thought originally might have some therapeutic aid, but more recently, it's shown some more negative effects. In large doses, it can actually destroy different serotonin neurons, which can produce long-term negative effects. It takes a lot of time to kind of get those back. We also have MDA, which is a little bit different, produces effects very similar to MDMA, but is a different chemical structure. We also have dimethyloxymethylamphetamine, or DOM, which is, again, another chemical structure similar in these. Oftentimes can produce feelings of serenity, tranquility, or peace, but has some of those same negative side effects as well. It's pretty potent. It's 100 times more potent as mescaline, and about 1/13 as potent as LSD. So sitting somewhere kind of in the middle there. But again, has more of these, amphetamine derivative effects. Then we have NMDA antagonists. So these are things that sort of work slightly differently. So an example here is something like PCP or angel dust, right? So this is technically a medically safe, but psychologically troublesome anesthetic for people. So these are drugs that medically may not produce any negative physiological effects, but certainly psychologically can produce profound and often harmful psychological effects. So again, we have examples like PCP or angel dust. These tend to be, things that come from, so it was called angel dust actually because it tended to be sprinkled onto things and oftentimes sold as marijuana in the 1970s. It would be sprinkled on like parsley or oregano. People would say, "Oh, it's marijuana," but it was actually, just those herbs covered in PCP. And this is interesting too. It has a similar mechanism of action to NMDA by actually affecting the glutamate receptor. So some effects here of PCP can be quite severe, but work slightly differently than some of these other drugs. Then we have ketamine. So this is another antagonist. Again, it works to kind of lessen those effects. It's less effective or it's less selective than PCP, but still has quite a strong effect. It also has been used sometimes to treat major depressive disorders and also produce sort of antidepressive effects in smaller doses. In larger doses, it can actually have effects that induce sort of complete loss of self. You may have heard of the term K-hole. This is the idea of basically falling into a psychological black hole of perception and awareness. And then, of course, we have some other examples here like memantine and deoxythropin, other examples, again, of these antagonists that work sort of to block sort of the effect of NMDA. All right, so again, these are derivatives of amphetamines. And so let me show you real quick. We'll go back, we'll jump over to mouse party here, and let's take a look at our ecstasy mouse. Is that what we've got? LSD. We'll come back to that. Let's take a look at our ecstasy mouse and throw him in the chair and take a look at kind of how this works as well for him. So what we can see for ecstasy is we see normally what's happening here is this effect of our normal production, normal effect of these neurotransmitters. In this case, we're looking at serotonin neurotransmitters, where we see their transporters bringing them back up and the receptors existing sort of in their natural state. What happens is when ecstasy gets introduced into this, it kind of mimics those serotonin receptors and gets absorbed into that axon terminal. So what's happening is that thinks there's a lot of extra serotonin, and so these serotonin transporters kind of get confused, and rather than absorbing the serotonin out of the synaptic cleft to kind of recycle it back into the mix, it starts pumping them out right into the cleft so that they're more readily available to be bound to those receptors on the receiving or that bottom receiving neuron. And so they're more often and going to continue to bind over and over again to those receptors. So again, it produces the effect of having more serotonin available in the system. And you see that increased effect of that serotonin on that receiving neuron. And again, what's important here is how this kind of affects certain regions of the brain. And we can see here that this affects, again, a pretty wide range of the brain, especially areas related to mood, perception, as well as sleep and appetite as well. But it acts on these reward pathways and just kind of simulates the extra level of these more positive neurotransmitters like serotonin in this case. All right, let's eject him and we will kind of move on from here. I guess we did skip over LSD. We'll throw the LSD mouse in here right now and take a look at him as well while we're here. And then we'll come back to the last one for our last use case. So let's look at LSD. So when we're talking about LSD, we see this coming in and binding to these serotonin receptors. Remember, LSD mimics serotonin in this case by actually binding to those receptors. It's so close to it, it can bind to the receptors. And what happens is based on the type of receptor, it's going to do different things. But we still see it affecting sort of this synaptic cleft, this synaptic transmission in different regions of the brain, which again produce different effects, sometimes blocking, sometimes exciting, which is why we get sort of that wild effect of LSD on the brain. It kind of has somewhat unpredictable effects when we look at this. And again, this happens on different pathways, different regions of the brain associated with different things. So in this case, looking at oftentimes sensory areas and connection points, pathways of connection within the brain. All right, let's go ahead. We'll eject this mouse. And I believe the last one we have left is going to be our marijuana mouse, which we will get to in the next chapter here in a second. So let's go back here. And actually the next chapter we have is going to be chapter 15. So let's go ahead and switch over to that. All right, let's cover the last chapter here, chapter 15, and this is all about cannabis. So we're going to go through some different things here. We're going to talk about how this plant is prepared and we get sort of the actual chemical structures from the plant itself. We're going to talk about the history a little bit here of cannabis. We'll of course talk about the pharmacology, how this works on the chemical structures of the brain. We'll talk about some physiological effects as well as some behavioral effects. and some cognitive effects here specifically as well. This is a drug that, of course, is very prevalent in today's society and has been studied to a different degree in some cases than many of the other ones we've talked about this semester. We'll talk about some benefits of the drug as well as some causes for concern and kind of wrap up with legalization of the drug kind of going forward. All right, let's go ahead and start off by talking about different preparations of the drug or the plant itself. So there's really three different species of cannabis that exist. There's cannabis sativa, cannabis indica, and then a hybrid or a cross sort of between the two. So cannabis sativa tends to be used more for its fibers and hemp, whereas cannabis indica tends to be more sought after for its psychoactive potency. So it tends to be more psychoactive, have more of those, chemical components to it. The main chemical component, the main psychoactive component, is actually THC, a tetrahydrocannabinoid or cannabinol, which is again THC, specifically delta 9 in this case. And so this is, again, the primary psychoactive agent in cannabis, and oftentimes can be concentrated down into different forms of resin that can make different types of chemicals that we'll talk about here in a second. The potency tends to get stronger the more it is compressed down into different forms of resin. And again, different types of strains can have different strengths of that within it. We see some of the strains containing up to, upwards of 30% pure THC in them, while other strains sometimes having as little as 1% THC. And these tend to have been, grown and produced and almost evolutionized over time to be stronger and stronger over the course of the last, few decades. So some of the forms we have here as well are things like hashish, which is a potent preparation of that resin that's kind of compressed down into sort of a almost chocolatey-like substance that again has a pretty high potency of that THC component into it. We also have sinsemilla, which is basically a method that is used to grow more potent marijuana, which is what I was just talking about, where more particular strains, more potent strains, stronger strains are selected and then bred together to create more and more of that strength or potency in the resulting offspring plants. So that's kind of how that works. And what happens here, how this is sort of produced and made, is that it's really the flower, right, from those female plants that is the part of the plant that produces that, that chemical structure, that THC, the hallucinogenic component to this. And what happens is those female plants needs to be removed or separated from male plants before they are pollinated with one another, so that they don't actually produce those flowers to the plants. So you kind of want those plants to be unpollinated so that it produces the the component that you're looking for. In terms of extraction, so there's a variety of different organic solvents that tend to be used to extract the THC from different plant material. So for example, things like ethanol or even liquid carbon dioxide can sometimes be used to, again, extract that material from the chemical itself. And this is done, especially in a lot of the legal locations, to produce this particular substance that can be used to then be baked into edibles and things like that. All right, let's talk a little bit about the history of marijuana, specifically in the United States. So in the early 1920s, there was actually the first sort of transition or shift in the perception of marijuana, which is where newspapers started linking marijuana with crime. And so interestingly enough, this started to increase the public interest in the substance, because before that, many people sort of were less aware of it. And so this also induced some early regulation efforts where people, because of this link to criminal behavior, because of this increase in interest, there was more concern about the use of this drug, and so regulation kind of increased. It became more of a thing that people were looking into. And this produced in 1937 the Marijuana Tax Act. And so this was kind of following in the footsteps of the Harrison Act, which we talked about, remember, was in 1914. And so this followed from that and started to tax the regulation of marijuana. So both the grower, the distributor, and the seller and buyer were all taxed along this process. So the government was actually making quite a bit of financial benefit from this, and it made it, as a result, pretty much impossible to deal with cannabis legally. So what this resulted in was a much more illegal kind of market for this product. Many states also made specific laws outlawing the possession and use of marijuana. So again, all of this regulation transitioned the drug into a more, illegal or criminal view of the substance. So we also have in 1944 the LaGuardia report. So this basically concluded that marijuana use had less serious effects than commonly believed. So a lot of these strong negative reactions by different authorities were motivated more by factors other than actual data, right? So a lot of this regulation and this fear was not truly, derived in data. It was more based on other subjective factors. And so this, had some effects as well to make marijuana less of a negative stipulation in society based on sort of this report. In the 50s and 60s, we saw use increase again from this sort of effect, where it became more accepted in society, and again, use peaked around the 1970s. Just before that, the Supreme Court actually declared the Marijuana Tax Act unconstitutional, and so again, sort of some reversal here, which is why we saw that peak around 1970. Where this was the general popular view of this drug being more positive in nature. Of course, since then, it has sort of changed and actually kind of gone back down and back up over time over the last few decades, whereas today it exists in a more positive light, which we'll talk about as we get to the end of this chapter. All right, let's talk about the pharmacology here of how this works specifically in the brain. So it actually has a pretty complex chemistry. So it's a little bit harder to say specifically exactly what it's doing because it's working in a couple different ways. So there's actually more than 500 different chemicals even present in marijuana, and about 100 of them are different cannabinoids. So we have cannabinoid receptors in our brain naturally occurring, as well as ones that we naturally produce. And so when we talk about the effects of this, it is hard to specify down exactly because of how many we're working with here. So how it is, actually, before we go into the inhalation, let's switch to mouse party. Let's watch this for that particular mouse. So we'll go ahead and we will grab the marijuana mouse. We'll throw him in the chair. And let's talk through this process. All right, so we're going to zoom into the brain and we're going to take a look at our normal functioning structure. This looks very similar to what we've seen in the past, I think specifically for heroin. So we see that cannabinoid receptor appearing here, those naturally occurring inhibitory neurotransmitters, right? So those will naturally occur to stop the release of dopamine. And what happens is, again, a natural cannabinoid that we have in our brain binds to those to stop them from releasing that inhibitory neurotransmitter. So since that does not get released, we can see dopamine is allowed to be released. And so that gets released into the cleft and binds to those receptors. So again, what THC does in this case is it mimics that naturally occurring cannabinoid, and it binds to stop the release of that inhibitory neurotransmitter. So very similar to some other ones we've looked at. The result here, again, is more dopamine in the system, more dopamine allowed to be bound over and over again to those receptors. And again, of course, this acts in different parts of the brain. Here, specifically, when we're looking at marijuana, it's often involved in different areas like memory, specifically short-term memory, also different parts of like the bodily awareness, making us feel calm and relaxed and things like that. So again, where in the brain this is working makes a big impact on this as well, even if you see a similar effect at the neurotransmitter level. The different regions of the brain mean it might play a very different role. And that's why we see differences between different drugs that appear to be doing very similar actions at the at the neurotransmitter level. All right, we'll go ahead. We will eject him back with his friends back to the party, and we will say goodbye to Mouse Party for now and wrap up back on our slides. All right, so complex chemistry, we talked about kind of how that works. Typically, how it is ingested is through inhalation, right? So we tend to ingest this by smoking the drug or smoking marijuana in this case. And it allows the THC or the chemical compounds to be absorbed pretty rapidly, right? So that's a pretty quick way of absorption and allows that chemical drug to be distributed throughout the body quite quickly. So we see the peak mood altering as well as different physiological effects tend to occur about 5 to 10 minutes after ingesting. That's when you get that peak sort of effect of the drug. If ingested orally, which can also be done, it's taken in and absorbed much more slowly, where we see those peak effects tend to occur about 60 to 90 minutes following that intake of the drug. In terms of metabolism, it has a half-life of about 19 hours. So again, much longer than most of the drugs we've talked about. Remember, that doesn't mean it's going to be effective that long, just that those chemical structures will be present in the body. It takes 19 hours for half of them to be broken down. So you can completely eliminate all of the THC and its different metabolites. It usually takes about 2 to 3 weeks for you to completely eliminate it from your system. In terms of the mechanism of action, we kind of just showed this here in Mouse Party, but again, it's going to block the inhibit of that, block the release of the inhibition of those inhibitory neurotransmitters. So it allows more dopamine to be released, and it tends to work on the CB1 and CB2 receptors, which again affect sort of different regions. CB2 specifically is interesting because it tends to be found outside of the brain, often in immune cells. So it has some suggestion, some research shows that cannabinoids may actually play a role in how we modulate our immune system, which is really interesting to me because I think that there's a lot of research that could be done here. And some early research does show that it's possible that, that the consumption of marijuana can disrupt immune functioning. So I think more research there is definitely warranted. The CB1 receptors are those that typically would be found throughout the brain, right? So this is what most of what we would think of. Its effects are being done on the different regions of the brain associated with movement coordination, memory, cognitive function, and things like that. Some different physiological effects we have here. So for example, when we talk about cardiovascular effects, this is a pretty well-researched area of this. So it does have different heart effects based on both the time and the amount of the drug that you've ingested. So not only that, but also the method of ingestion. So whether being smoked or consumed orally, it's going to affect these different outcomes. And so when we're talking about cardiovascular, we're looking at heart rate here. So we can see, if we look at the first graph, when smoked, we can see that peak heart rate occurs about 10 minutes after that first inhalation period, and then tends to go down after that to lower amounts. Whereas for the oral THC, it takes closer to 90 minutes actually to see that peak heart rate appear. So again, we can also see we get that higher heart rate increase for the higher concentration or the higher dose in red compared to those other lines as well. Some other just general physiological effects we see are things like reddening of the eyes, dry mouth and throat, often from the smoking component, different pulmonary or breathing effects. These can be both acute, so pretty low effects acutely on breathing, though there may be subjective effects of this. Most of the time it doesn't actually affect your breathing. However, chronic heavy marijuana smokers tend to have, again, significant sort of lung impairment, similar to smoking other forms of really anything. Smoke in itself is bad for your lungs, regardless of the chemical that you're smoking. In terms of behavioral effects, we see a few different things here as well, and we can talk about sort of different effects. And oftentimes what's interesting is experienced smokers oftentimes are more easily able to distinguish these different effects. All right, so we have some subjective effects, right? So obviously this euphoria or this high feeling, mellowness, effect happens, as well as hunger tends to increase. Oftentimes it can also lead to paranoia, especially in more infrequent users, and then also rarely as well hallucinations, especially when consumed at higher levels and for more infrequent users. It affects food intake. Often it's pretty documented that marijuana increases the amount of food people tend to consume, and this can be beneficial in different types of medical uses, such as the treatment of different cancer drugs and things like that reduce appetite. We also see some verbal behavior. So this is really interesting to me. But verbal exchanges, so actual words and communication, tends to decrease. So people speak less when they've consumed marijuana. However, nonverbal social interactions tend to increase. So ways that you communicate with people without actually speaking, maybe using your hands or other forms of communication, tend to actually increase, which is kind of interesting to me. In terms of the cognitive effects, we can talk about this again from an acute perspective, meaning short term. We're looking at some effects that happen. Things like slowed cognitive processing, disrupted short-term memory, disrupted inhibitory control, loss of the ability to sustain concentration or focus, and then also some disruption of visuospatial processing, or kind of the perception of the world around you. This is mostly often for infrequent users, tend to get most of these effects. Frequent users often get these as well, but those effects tend to be diminished. So less of these cognitive effects for frequent users than for infrequent users. Those frequent users can oftentimes be tolerant to some of these effects. In terms of chronic use, so long-term cognitive effects, there's really no definitive findings in this area. So most of the research suggests that after 1 month of abstaining from consuming marijuana, very few cognitive effects actually remain. So you're able to kind of recover from any of these after not consuming marijuana for about a month. Let's talk about some benefits now. So in terms of benefits here, we of course have some different medical uses, right? So these medical uses sort of declined before the 1937 Tax Act for a few different reasons. Number one is just because there were better drugs, right? So other medications to treat these illnesses came about, were discovered, and they just kind of worked better. The method of administration, right? So most of these most of the ways of ingesting marijuana is through either, smoking or orally, which tends to either be harmful to the lungs or have a very delayed onset of the effects if taken orally. Whereas many of these other drugs for the medical use side of things could be injected, right? Marijuana isn't able to be because it's not water soluble, so it can't actually be, injected that way. So because of that delayed onset of the oral medication and the danger towards the lungs of the smoking, these other drugs tended to be favored from a medical use. However, recently some renewed interest in medical use has come about, specifically for the treatment of things like glaucoma, chemotherapy, especially for the positive side effects of mood and increased food intake, as well as to increase appetite in different patients suffering from AIDS. Of course, there are causes of concern to discuss as well. Number one being tolerance. So tolerance to different marijuana effects tends to develop pretty quickly after regular use, but that development isn't uniform, and it's pretty hard to have documented and well-established sort of regulations on these tolerance buildups. So the ability to sort of treat one person who's a frequent user to someone else who's a frequent user may still have very different experiences. Withdrawal symptoms, really research shows that withdrawal symptoms don't really exist. They're not life-threatening, but they can sometimes be unpleasant. Withdrawal symptoms do exist. They're not life-threatening, but they can be unpleasant. And that, they tend to not be quite as bad as many others, but they often can last for a little while, sometimes even 4 to even 12 days of withdrawal symptoms, including things like anxiety, irritability, disrupted sleep, or decreased appetite and food intake. Again, withdrawal tends to be the opposite of the effects that you feel on the drug, and so this is things that we would tend to expect. Not life-threatening, but certainly unpleasant. In terms of toxicity, when we talk about the acute toxicity, we can talk about things like generally the biggest risk here is increased heart rate. So this could be harmful for someone that has pre-existing cardiovascular issues, but for anybody else, most of the time this is pretty benign. There have been no recorded human overdose deaths from marijuana to date, so we tend to say on an acute level, it's pretty benign. In terms of chronic use, the most severe issue here is going to be associated to that respiratory effect. So especially someone who is smoking the marijuana, it's really going to lead to different forms of lung disease is the largest cause for concern here. So many of the carcinogens in tobacco and in cigarettes are still present in marijuana smoke. So you get that same sort of risk factor that we would expect for cigarettes. So it's not clear exactly yet whether that it shows an increased risk for cancer for marijuana smokers specifically, but it certainly would be logical to think that that could be a concern. In terms of vaping, so vaping was sort of brought about to help reduce this toxicity or this danger of smoking. And while it avoids the combustion of the drug itself and the creation of the smoke, it causes some fewer respiratory symptoms. It still isn't perfect, right? So it still is, administering different chemicals to your lungs that are not supposed to be there. And so it does have some level of toxicity, though far less than actually smoking does. Anxiety as well, another potential here. This is something that definitely happens to many people that have used this drug. It's characterized by fear or loss of control often, where you aren't able to sort of control your mind in this case. And some people seek treatment. Some people might go on sedatives or things like that for this, but it's definitely a cause for concern that can develop from marijuana use. Coming back to that immune system, right? So it's possible that it has some ties to the immune system. There's been some mixed findings on this. some suggesting that marijuana reduces immunity to infection, but others kind of showing some different findings. So it's not a clear, there's not a clear answer here. But like I said before, I think this is a really interesting thing to continue research on and look at how marijuana is tied to our immune system and how it might be, potentially able to be used or adapted in a beneficial way. Of course, marijuana madness, a thing back from a while ago. Some studies talking about the correlation between marijuana use and psychotic symptoms. Of course, most of these studies tend to be, correlational in nature, and causation is really hard to determine. Many of these people may have had psychotic symptoms prior to the use of marijuana, but the use of marijuana could have certainly increased those effects. So it's hard to draw clear conclusions here, but it is something that has been noted in the past and in the research with a link between these. And then I'll kind of end here on the toxicity or cause for concern on the driving ability. This is a huge area of research, something that many people debate and talk about today, especially in the states where marijuana is legal, how to go about regulating and maintaining the safety of driving and roads for people that consume marijuana and choose to drink or choose to drive. We have lots of regulation on drinking and driving, so mimicking that with marijuana is something that is a challenge for many different reasons, and something to certainly talk about kind of going forward. This is also more significant for infrequent users. You tend to see larger driving ability loss compared to frequent users of the drug. So again, how do we sort of develop regulations and rules around this that apply to everyone is a challenge to kind of figure out. All right, then we will end here talking about the legalization of marijuana and how that has sort of progressed throughout our country, at least here in the US. So currently, 38 states have legalized medical marijuana at least, and you can see even more in this graph under different regulations. So there are lots of different classifications here of how this works. The dark green being fully legalized and just able to be purchased. The slightly less dark green, both legal medically and it's also decriminalized. The other green, just medical, light green, is only decriminalized, meaning that it is still not legal, but that the persecutions are far less. And then some states where CBD can be sold with small amounts of THC in it. And then, of course, those orange states where it is still fully 100% illegal. And of course, us being in South Carolina fall into one of those 4 states left in the US where it is fully illegal. So just some history here of how we got here. In the 1970s, actually most Americans didn't support marijuana legalization. So there was, even though there was the notion that it was pretty prevalent in the US, most Americans still didn't support the legalization of it. By 1978, though, support had risen to about 30%. And today, actually, almost 88% of US adults support some form of marijuana legalization, either for medical use or for recreational or full legalization. So this has definitely changed over the last few decades, where we've come to a point where most people tend to be under the mindset of legalizing it for one purpose or another. And you can see the US, based on this graph, that is pretty indicative of those relationships. However, it does still remain a Schedule I drug, meaning that from the federal level, from the FDA, it is still considered a dangerous drug with no medical utility and should be fully sort of regulated and kept illegal. So from a federal level, it is still illegal and something that I expect we will see some potential change in the near future, though that is quite hard to predict. People have been saying that for a long time, and it'll be really interesting to see kind of how this develops going forward. All right, that is the end of this chapter and this section. So I'm going to go ahead and wrap this up and stop here.